Gestational Diabetes by Angelique Bach, Marcus McKenzie, Deanne Myers-Magbaugh, Howard Taylor, and Tiffany Reeves. What is gestational diabetes? Gestational diabetes is a medical condition in which the beta cells of the islets of Langham does not produce enough insulin to metabolize blood glucose during pregnancy. Pathophysiology usually starts during the last half of the pregnancy or as early as 20 weeks of gestation. According to the American Diabetes Association, gestational diabetes occurs when the body is unable to make and use all the insulin needed for pregnancy. Cells become resistant to insulin, leading to an increase in blood glucose levels. Pathophysiology continued. Develops in pregnant women who have never had diabetes. Baby will have higher risk for health complications. Usually goes away after your baby is born, but increases chances of type 2 diabetes later in life. A baby is more likely to be obese as a child, teen, and more likely to develop type 2 diabetes later in life too. Clinical manifestations. Polyuria is the production of abnormally large volumes of dilute urine. Polydipsia, excessive thirst. Polyphagia, excessive hunger or increased appetite, and weight loss. Some risk factors: obesity, history of gestational diabetes, prior pregnancies, family history of gestational diabetes or type 2, glycosuria, condition of excessive sugar in the urine. Women at higher risk, screen for diabetes at first prenatal visits. Diagnostic criteria includes fasting glucose test, a 2-hour plasma glucose tolerance test, A1C test, 2 or greater than 6.5%. Women at average risk, screen between 24 to 28 weeks. Diagnosis of gestational. Some risks continued. Maternal risk, hydramnios, increased amniotic fluid in urine, preeclampsia, which is hypertension, ketoacidosis, increased susceptibility to infections, which is UTI and monovaginous, and some fetal and neonatal risk, perinatal mortality, not treated, too big, congenital anomalies, 6 to 12% with the heart, macrosomia, large baby, damage of the vaginal canal, intrauterine growth restriction, and respiratory distress syndrome. Some diagnostics. Screening is done at 24 to 28 weeks gestation. Fasting glucose of 94 or greater than. Fasting glucose, that is, 2 or greater than 126 grams, 200 milligrams, a 2-hour plasma glucose tolerance test, an A1C that is equal to or greater than 6.5%, and must have 2 to 3 to be diagnosed. Some treatments: pharmacological, insulin administration. Some of the regimen is individualized. Glyburide and metformin may be safer during pregnancy. Human insulin is preferred. The non-pharmacological is diet, 300 calories per day, exercise, strict blood glucose monitoring, and assessment of the fetal status. Patient education. Educate the patient on appropriate diet modifications. Encourage regular exercise regimen. Encourage medication regimen. Consider the risk and benefits for all medications. Emphasize the importance of strict glucose monitoring. And consider the time of the birth. Nursing diagnosis: impaired nutrition, less than body requirements related to insulin deficiency, decreased uptake and utilization of glucose by the tissues, resulting in protein or fat metabolism, as evidenced by increased urinary output and dilute urine. Nursing diagnosis interventions. Number 1, weigh daily or as ordered by HP. Assess adequacy of nutritional intake, which includes absorption and utilization of nutrients. Number 2, identify food preferences, including ethnic, cultural needs. If the patient's preferences are incorporated into their care, they are more likely to cooperate with the dietary requirements after discharge. And number 3, provide fluids containing nutrients and electrolytes as soon as the patient can tolerate oral fluids. Progress to normal diet as tolerated. Oral fluids is preferred when patient is alert and bowel functions have been restored to normal. Nursing diagnosis outcomes. Number 1, ingest appropriate amounts of calories and nutrients. Number 2, resume normal or as close to normal as possible energy levels. And number 3, demonstrate a stabilized weight or gain towards usual desired range with normal lab values. NCLEX questions and rationales. Number 1. The nurse implements a teaching plan for a pregnant client who is newly diagnosed with gestational diabetes mellitus. Which statement made by the client indicates a need for further teaching? A. I should stay on a diabetic diet. B. I should perform glucose monitoring at home. C. I should avoid exercise because of the negative effects on insulin production. And D. I should be aware of any infections and report signs of infection immediately to my healthcare provider. The correct answer is C, and the rationale: exercise is safe for a client with gestational diabetes and is helpful in lowering blood glucose levels. Dietary modifications are the mainstay of treatment, and the client is placed on a standard diabetic diet. Many clients are taught to perform blood glucose monitoring, and if the client is not performing blood glucose monitoring at home, it is performed at the HCP's office. NCLEX questions and rationales. Number 2. A patient with gestational diabetes should expect A. To need an increase in her insulin during the third trimester of her pregnancy. B. Her dependence on insulin is lifelong. C. Her newborn infant to be smaller than an infant to a non-diabetic mother. And D. Her baby to require insulin as childhood diabetes will set in immediately. The correct answer is A, and the rationale: the placenta releases hormones that increase cellular resistance to insulin. The amount of these hormones increase with the progression of the pregnancy. Therefore, the amount of insulin necessary to control blood sugar is increased. And these are your references.